Well, thank you. I believe this is sort of the last session of BAUS, and I feel privileged to be here at the end, along with our very distinguished panel. So we've heard some evidence. This is discussion over the next half hour or so is going to be more of the art of urology rather than the science. We're going to use best evidence as a panel, expert opinion, anecdotal experience, and we're going to put that in the melting pot, and out of it we're going to bring out a magic potion that'll make our patients better. And that's why I think this type of panel is very helpful in the murky world of chronic pelvic pain. We have two cases. We'll start off with a male case, and if we have time, we'll go on to the female case. And I thought what we would do, because the easy patient is simple, that we'd hope the panel does not mind, but we're going to use a more complex type of patient. And the first patient is one that we all see, the patient with more than one condition. This particular patient of mine, which may or may not have, as Chris said, you know, how he would manage it might be different than myself, but I was going to show you how I manage it, but we'll see how the panel would manage this patient who presents with 69-year-old. He's referred with bothersome LUTs, erectile dysfunction, and genital urinary pain. And yes, I see a lot of this, and I'm sure you do too. So just to start with Duncan, what else do we need from history? And I don't mean, this is not a registrar's examination or a residence examination. What important things do you need in clinic while you're there?
I think you just need to quantify all these three conditions and find out the degree of bother and which one they're most bothered about, to be quite honest. Okay,
I think that is the absolute key, is that there's three conditions. The problem is it does take almost 3 times as long, because if he just had BPH LUTs at 69, it's easy. If he has ED, it's simple. If he has CPPS, well, I provided a bit of a plan before. So I'm going to kind of agree with Duncan. So this particular patient is really healthy, no major problem. He does have symptomatic lower urinary tract symptoms with storage and voiding symptoms, has poor quality erections, but only moderate bother, constant but varying of intensity and bothersome perineal discomfort and post-ejaculatory pain. Hashem, anything else that you would want to know from history or initial evaluation?
I would tend to get them to do a urine dipstick, make sure they have no infection, and also do a frequency volume chart and a flow test and residual.
Chris, would you do a frequency volume chart right off on this patient?
Yes, certainly. I think it's essential because it helps you quantify the problem.
Yes, I started using frequency volume charts. I was a late bloomer to the value of these only about 3 years ago, and I have found them very, very helpful. The only unfortunate part of it is you don't get the information until the next visit, which is okay, because in this complex patient, sometimes a second visit is important and not just start off on therapy. So in this patient, the frequency volume chart shows that the patient does have frequency, he's up, does have nocturia, but he has no evidence of polydipsia or nocturnal polyuria. Patient reports urgency, but does not have the urge incontinence. Poor quality erection, yes, it affects his sexual enjoyment, but the LUTs and the pelvic discomfort are the major symptoms impacting on his quality of life. He's concerned about prostate cancer, but he's well read and knows that the last thing he should have is a PSA, because he realizes the evidence that PSA causes more harm than benefit. So Hashem, what investigations would you consider for this patient?
So a flow test would be sort of prudent here to look at how he's voiding. Just going back to your comment about the frequency volume chart and requiring a second visit, we actually send our frequency volume chart before the patients come to the clinic, so we have a LUTS clinic.
That's excellent idea.
So that saves a clinic visit, but certainly a flow test would be prudent here with a residual to look at the pattern of the void and how much he's leaving behind.
Okay. Duncan, do you do in your clinic, and you got to be honest with this, do you do any type of prostate-specific cultures in a patient who has chronic pelvic pain, so-called prostatitis? In other words, do you do a prostate massage after your prostate examination and get another urine specimen?
Absolutely not.
Absolutely not. Chris?
No, we don't either. What I'd also like to know with this gentleman is what sort of volumes he's voiding. You mentioned he hasn't got polydipsia, so I'd suspect he's voiding quite small volumes if he's going that many times.
Yes.
And he hasn't got nocturnal polyuria, so that's another bit of information would be useful.
Very good. Okay. So in this particular patient, on examination, he has tenderness in his lower abdomen, pelvic floor, and exquisite prostate tenderness. He has an estimated prostate volume of 40 cc's by transrectal ultrasound, peak flow rate of 9 cc's. We estimate his prostate volume is 40 cc's, and that's estimated with the accurate finger. The post-void residual by ultrasounds, 30 cc's. Midstream urine culture, which is sent, becomes sterile. And I do a post-prostatic massage urine in this patient with prostatitis. 8 to 16% of patients will have uropathogens. All it really does is gives me the license to prescribe a lot of antimicrobial therapy to this patient, and I can go to sleep at night not worrying about the potential complications. His PSA, which we did do, and he was convinced that the PSA was not being done for prostate cancer screening. It's more for case detection to make sure prostate cancer was not causing all these symptoms. And secondly, it may help us determine therapy was normal. Do you do, and this is Hashem, would you do testosterone or hormonal screen on these patients who have LUTS and ED?
Not routinely.
Anybody does them routinely? No. Either would
I think
we.
this guy's got enough trouble as he has already, and if you start throwing that into the mix as well, it just increases the complications.
That's
unless
right.
he describes a lower libido.
Great. Chris, so what is your diagnosis? The patient walks, he wants to know what he has.
What sort of volume did he void with the flow rate of 9 mils per second? Because that's obviously very important. It's got to be more than 150 mils, otherwise it's difficult to interpret that. But
in this particular patient, I cannot remember.
Oh, sure. But in this case, I mean, you've got a guy who's going very frequently. He's got overactive bladder symptoms. He's got pelvic pain of some sort. Presumably his prostate, because it's tender, you think that might be the focus. He's got lower tract symptoms, which are possibly related to degree of outlet obstruction, depending on that sort of flow. It could be underactive bladder, but he hasn't got a significant residual, so that's less likely. And of course, with LUTS and pelvic pain, it's very common to have erectile dysfunction. So the question here is whether he's got a bacterial prostatitis, you've got a sterile urine, or whether he's got a degree of benign prostatic enlargement causing obstruction, or a combination of both.
Mm-hmm. Any other comments? Duncan, Hashem?
No. The flow rate should exclude the urethral stricture as well. So looking at the pattern of the flow is prudent to see, is this, as Chris said, BPE type flow pattern or a stricture pattern?
Right.
I think unpicking for the history, it's difficult to sort of get the sense, but it sounds like he's more bothered about his pain than anything else. And I think if you address the pain first, you might find that his erectile dysfunction, which he says not too bothersome, may actually resolve.
Right. So I'm going to agree. He would, in my clinic, would be sort of a complicated patients with LUTS, ED, and CPPS, chronic pelvic pain syndrome. Now, do any of you start out with Chris? Are these related? You
Yes.
kind of alluded to that in what you said.
Yes, and certainly, I mean, there is certainly evidence going back, it's rather historical now, that you've got intraprostatic reflux if you've got a degree of outlet obstruction. Certainly there's also good evidence, and you've contributed significantly to the literature on that, about pelvic floor spasm causing this. And indeed, in certain parts of the world, it's common in women too that you get this pelvic floor spasm causing these symptoms. And we do know that these patients often, if they go into a more relaxed environment on holiday or whatever, they find their symptoms get better. So there's no doubt that a degree of intraprostatic reflux related potentially to outlet obstruction of some sort, often muscular, is possibly responsible.
Right. Duncan, would you agree that pathophysiologically there may be an association between BPH, LUTS, and CPPS?
Yeah.
Any of you want to suggest a mechanism besides the sort of physiologic mechanism, maybe even more down to what's actually going on? I'm going to suggest one. I'm going to suggest these may all have to be related. The ED, the lower urinary tract symptoms, CPPS, may be due in some respect, in some patients, to local pelvic organ ischemia. Might be related to ischemia of the bladder, the prostate, the CPPS. and then you add the further obstruction to throw into the mix. In fact, our studies have shown on a number of databases that 16% of men with BPH have prostatitis-like symptoms. We know the relationship between ED and BPH. There's many studies have shown that there might be a causal relationship, but certainly there's a prevalence relationship as you age with, and the severity of LUTS is correlated with the frequency of ED. We know that ED plays a role, is one of the parameters that we assess and are associated with CPPS even in younger men. So in fact, all these three conditions could be all interrelated in this particular patient. Then we can throw in the metabolic syndrome, and we can throw in a lot aging and a lot of other things. Any comments on that, or am I just
No, I
sort of
think
singing
that
to the wind?
You raise the point about ischemia, which is one of the hypotheses that there is some support for. One of the things against it is that obviously an alpha blocker, by improving symptoms, for instance, which doesn't improve ischemia necessarily, well, not the evidence would suggest it doesn't, also improves erectile dysfunction. Now, obviously, the ischemic hypothesis is a very reasonable one. Alison Brading and the work there suggesting obstruction caused ischemia of the bladder. And obviously, if you've got metabolic syndrome, there could be arteriosclerosis leading to ischemia. And as you imply, a PD5 inhibitor by improving ischemia, although the thing against that is that PD5 inhibitors are now thought to work by afferent mechanisms, not necessarily by vasculogenic mechanisms. So the jury's out on this at the moment.
Yep. So how would you treat this patient, Duncan?
I'd probably start with an alpha blocker initially, and probably some ciprofloxacin and some ibuprofen.
So number one is alpha blockers. Hashim, would you agree that alpha blockers would be your primary therapy?
It will be my primary, but if his overactive bladder is also bothersome, I would add in an antimuscarinic at the same time.
Chris?
No, I would agree with those suggestions.
What about the antibiotic suggestion?
Yeah, I mean, I would often, and I know it's becoming less acceptable now, but I do find a lot of these patients do benefit from a combination of an alpha blocker and a low-dose antibiotic. But I think with our concern about resistance, it's becoming less acceptable.
It's kind of interesting that in the 1960s and the 1970s, before we had alpha blockers, before we had 5-ARIs, the most common treatment for BPH LUTS was trimethoprim sulfamethoxazole, Septra or Bactrim, was the primary therapy we used, particularly in men who didn't want to have surgery. We gave them some antibiotics, particularly if they had a little ejaculatory discomfort or stranguria, bang, antibiotics. And anecdotally, some patients maybe, perhaps, possibly, didn't have to have surgery and may have gotten better. Studies have shown that in chronic non-bacterial prostatitis, chronic powerful pain syndrome, that a trial of antimicrobial therapy, such as a fluoroquinolone for 4 weeks, might actually improve patients despite whatever the culture showed. And there's all sorts of reasons, including it might be reducing inflammation, it might be taking care of occult bacteria that are causing infection, or working on microbiomes, or not microbiomes, but working on biofilms to suppress them. Who knows, but a certain percentage of patients do get better. I think if patients have been on antibiotics, have negative cultures, and don't get any better, giving them further antimicrobial therapy or changing it is going to be of no value. I also think that 4 weeks therapy will predict any longer therapy, and we've actually shown that with a 12-week trial with ofloxacin very early on. So I agreed too. This patient, I treated him with an alpha blocker primarily because I was waiting for the other tests to come back, and that was my first test that he came back. So that he came back and the storage symptoms persist, remain bothersome. Now, Hashim suggested an antimuscarinic. That probably would have been, for this particular patient, an ideal situation. And ED was not impacted at all. The ejaculatory pain may have been a little bit better, which sometimes happens with alpha blockers, but the perineal pain is still bothersome. So at this point, Chris, Hashim's already thrown in his idea of an antimuscarinic. Would you consider adding an antimuscarinic to the alpha blocker?
I mean, you certainly could consider it. He's got a low residual, so there's no contraindication. I mean, this case, I'd see how he got on with the alpha blocker first, but if he's still having problems, you could certainly consider that.
Right, so his voiding symptoms are persisting. His pain persists. So we did add an antimuscarinic, and he was happier about his daytime frequency. The bothersome nocturia persists, but really he was only getting up twice a night. So, you know, what are we going to do that with a 67? Had no impact on his ED, had no impact on his CPPS. So we won't go into the evidence for the combination, but it's pretty well accepted in the UK that the combination of antimuscarinics and alpha blockers is acceptable in the appropriate patient. Is that correct?
Yes, there's a marketed drug combination which is licensed for use.
So you have the combination medications. We don't have the combination medication yet available in Canada of the two, so we tend to use as add-on therapy, such as I did in this particular case. Hashim, beta-3 agonist consideration. I don't know if we have a beta-3 antagonist.
Yeah, I mean, you can add in mirabegron, which is a beta-3 agonist, but I would tend to start with an antimuscarinic, and if that's causing problems, then I would add in either, if he's getting benefit, then add in a mirabegron as well, or instead of the antimuscarinics for his storage symptoms.
Right. So let's say this continues. His ED isn't better, his CPPS isn't better, but his voiding and storage are better. Duncan?
It's tricky, isn't it? I probably might think about some urodynamics, actually.
Urodynamics. This is now the time, urodynamics. Maybe even cystoscopy.
Yeah. Yeah.
Okay. Why? His voiding and storage symptoms are completely better. He has ED and CPPS. So I have to throw that out because I didn't do urodynamics. Didn't even cross my mind at this point.
Okay. Yeah.
So would you consider a PD5 inhibitor in this, and how would you consider it? Yeah, go ahead, Duncan.
Yes, I would. And I would probably do tadalafil 5 milligrams once daily.
Right. So the traditional way that we would do it with this patient was keep him on the alpha blocker, put him on the PD5 inhibitor on demand to try and take care of his ED. But in this particular case, we could do the 5 milligrams. Chris, do we stop the alpha blocker?
Yes, I mean the evidence is there's 3 or 4 studies, and there's one which is a European study which compared tamsulosin and tadalafil and found equal efficacy. I'm not aware of any good evidence that combination is useful, and so certainly you could use the tadalafil instead of tamsulosin. Indeed, when it comes off patent, it'll probably replace the alpha blockers in terms of the patient's choice. The question, though, is cost, and that's the major issue in the UK, because it is expensive and it wouldn't be very popular with our general practitioner colleagues who'd probably, even though it is allowed, it's not on Schedule 2 for that particular indication, but there would be a rebellion and we'd be getting letters back complaining about it.
Right. But in this particular patient, it is something you could offer the patient. Hashim, would you keep him on the antimuscarinic you started him on?
Yeah, I would keep him. If it's improved his symptoms, I would keep him on it, definitely.
Okay, so that's what we actually did. We discontinued the alpha blocker. We did the tadalafil. So Hashim, we really don't have any evidence of using a PD5 inhibitors plus antimuscarinics, do we?
No, but I don't think there's any contraindication of using the two together. So
right. Duncan, do you think the tadalafil could have any impact on the CPPS?
I think so. It's a very complex condition, isn't it? I think anything that may potentially have a benefit is worthwhile trying.
Yeah, we've been actually surprised, and we've had very good success in patients, particularly once the urinating symptoms have been controlled, is that patients do very well if they have the prostate-specific U-point domain. And in this particular case, we did see some benefit, but not a lot. Sometimes we see more than that. So the patient is on tadalafil and solifenacin. His LUTS is improved. His ED is improved. Remember, he wasn't that bothered. He's satisfied. The CPPS is still bothersome. Which one of you guys are going to tell me what his U-point definition is? Let's start off with you. He had U, which is being successfully treated. P, guy's a regular, as you guys would say, bloke. I love using that word. This is probably the only country in the world I can say bloke and get away with it. So he's probably a regular fellow, and so he doesn't have any psychosocial major things. O, the organ specificity, yeah, he has prostate problem. The prostate was enlarged, probably causing obstruction because he got better with the alpha blocker. It shows inflammation in the microscopy that I did. I, no infection. I didn't try him on antimicrobials. N is the neuropathic, outside the pelvis type pain, doesn't have any of that. T, yeah, he probably has pelvic floor dysfunctional pain. So if we go on that and look at a CPPS, I'm just, for the sake of time, I'm just going to basically say his voiding symptoms are under control with a combination of tadalafil and antimuscarinics. His ED is under control with the PD5. So we would use conservative therapy, add no more medications, diet modification, activity modifications, exercises, donut cushion, heat therapy, which is, judicious use of a high quality heating pad. And it has to be a high-quality heating pad because we had a fire in one of my patients, and I don't know how he was doing it, but he turned it up and it got a short, and the next thing you know, he had a burn, and the couch was burned, and everything was burned, and I was burned. And physiotherapy, because physiotherapy is very valuable as long as you get physiotherapists who actually know how to deal with pelvic pain and do the exact opposite that they would do for your men with post-radical prostate incontinence. If that doesn't work, we use second-line therapies, and this will be, because he's already on 2 medications already. So second-line medications, we would go perhaps for the herbal therapies. Herbal therapies such as quercetin and cernilton have proven efficacy in randomized placebo-controlled trials, even though it's only 1 trial each. They have very few side effects. They cost enough to the patient to potentially have efficacy, and they come in neat boxes with lots of official stuff on it. So the patients will at least get a very good placebo therapy and probably better.
Can I just put my hand up for the evidence-based bit? Because none of the guidelines recommend those because, as you say, they've got very limited evidence.
Well, actually, the European guidelines now do have that in because of the recent German trial using cernilton. Yeah. The quercetin, what evidence is there in a 26-patient randomized placebo-controlled trial, which is the only evidence that we have for that. The phytotherapy, saw palmetto, the evidence is conflicting. So that's where the art comes in. Patient sometimes wants a pill for this, and so why not use, the best placebo that's available that might even have some reasonable efficacy. And yes, that's the art rather than the evidence-based science. You're absolutely right to catch me on that. Muscle relaxants we do use. I tend to use cyclobenzaprine, Flexeril, the old Flexeril, but baclofen and diazepam, of course, are used as well. In this particular patient, I didn't have to use any of that. So complex cases such as this, I think, require complex solutions. We have to look at the patient's phenotype, and the panel did a great job of honing in on characterizing and defining what the patients had, and then directing therapies for each one of the various presentations in the patient's clinical picture. And then in these particular conditions, in male LUTS, ED, and CPPS, they're overlapping conditions, and the solutions can be overlapping. And sometimes, as our conversation with Chris, sometimes we can go outside the guideline box when we're treating these conditions, and sometimes add a little bit of art based on anecdotal expert opinion and what evidence is available. What would you like me to do? 5 minutes? Well, let's just quickly go through a little bit of case 2. Because we have 5 minutes, we aren't going to go through very much of this. This is the female with chronic pelvic pain and LUTS, frequency, urgency, bladder pain impacting on her quality of life. The panel, since we have 5 minutes, do you mind if I don't ask you the examination question of what do you get next? Because we all know what it is. We have to get a relevant medical history. And the relevant medical history is this patient has things going on other than the bladder. Migraines, constipation and diarrhea, as well as the frequency, urgency, but no incontinence. And I do like that sign that the patient tells me, at least for a temporary bit, that their pain gets better after they void. And physical examination shows evidence of bladder and pelvic floor pain. Everything else is normal. The frequency voiding chart is very helpful in these patients. In this particular patient, it showed that she was not drinking very much based on the fact that her urine output was very low, but she still had the frequency and nocturia. So the question is, Chris, cystoscopy.
Yes, in this sort of case, I mean, you're thinking bladder pain syndrome, painful bladder, interstitial cystitis, whatever you want to call it. And in this context, I wouldn't do a cystoscopy under local anaesthetic. I would proceed straight on to a cystoscopy under general anaesthetic for two reasons. First of all, the evidence as it exists would suggest that it's very useful from a point of view of diagnosis to see what the bladder looks like after you've stretched it. Now, glomerulations aren't important, but if you're getting a Hannes ulcer or bleeding. Secondly, to look at the capacity. From my perspective, that can be a very good prognostic indicator. If you've got a young patient who's got a very small capacity, anatomical capacity, they don't do well with conservative measures.
Right.
And that's a very useful diagnostic thing. Secondly, therapeutically, some of these patients do get considerable symptomatic benefit from stretching the bladder with a meter of gravity fluid fill under anaesthetic and doing it for 3 or 4 minutes. The evidence base is limited, but that's what I believe the international guidelines would support at present.
Hashim.
I sort of agree. I look at the frequency volume chart. If the patient has a good functional capacity of, say, 500 or 400 to 600, then I would do a cystoscopy on the local and see if she gets any pain that way. But if her capacity on the frequency volume chart is reduced, then I would do a general anesthetic cystoscopy.
Okay, so the European guidelines, and UK is sort of in Europe, I still believe, state that general anesthetic hydrodistension is a part of the evaluation. In the United States, it emphatically stated in the 2010 guidelines that cystoscopy is not part of the routine evaluation. The Canadian guidelines was wishy-washy in 2008. The new guidelines are being presented at the CUA next week, and what we're presenting is the Canadian compromise is a cystoscopy under local anesthetic. The reason being is that you get functional bladder capacity. What is the bladder capacity with pain, which is also very important, and I think predictive as well in what's going to happen. You also can, and I firmly believe that you can pick up Hunner's lesions without doing a hydrostatic bladder dilation. Sure, you miss some of the bleeding from the Hunner's lesions, and you miss many of the glomerulations, but you can avoid that by doing an anesthetic challenge test, by putting a lidocaine bicarb into the bladder, doing another capacity, which is your anesthetic bladder capacity, which in most IC patients will double over what the functional bladder capacity is with pain. You will get glomerulations. The Hunner's lesions then start to bleed, but not only that, the bladder pain gets taken out of the situation, and you can examine the pelvic floor and vagina with no bladder pain. And that's basically what we did with this. I was going to ask Duncan, urodynamics. Would you have done urodynamics in this patient?
No, I would have done the general anaesthetic cystoscopy first and see how she went with the distension.
Right, and I'm not going to argue against that. I think, I don't know if it's that wise in resources. The other problem is, Chris is right, some patients do get better for a temporary period of time. It's usually measured in months, and they'll want it again. And the evidence is showing that repeated dilations, probably through intramural fibrosis or whatever, each time you dilate it, you get smaller capacity, and that's probably iatrogenic. Repeated dilations might cause some patients more harm in the long run.
I mean, some of these patients also have so-called urethral syndrome. If you over-distend the urethra, it doesn't seem to cause incontinence, and some of them, particularly the younger ones, get great benefit. It's quite difficult to do that under local.
Yeah, it can be done, but you're right, it is difficult. That's why all my difficult patients, particularly the ones that you don't do one, will go on to general anesthetic. There's the results we get with the increase with the anesthetic challenge. The diagnosis is bladder pain syndrome. We have our conservative treatment, our first-line interventions, our second-line therapies, and as you can see there's no pills in this at first and second line. For this patient, we would use a lidocaine bladder desensitization program, and only in second line do we go to neuromodulation with amitriptyline. Response to therapy wasn't that bad. Modest improvement. We added mirabegron. So to end with, I'd like to say don't put patients into diagnostic silos in these type of patients. Be willing to adapt the situation. So, do you have to do a general? Do you have to do a local? No, you can put them around. Treat the patient's individual clinical phenotype, so every patient gets treated differently. And do consider multimodal therapy addressing the main pain generators and urinary problem. But like in this patient, we didn't go into detail, but treat the IBS and the pelvic floor with diet, medication, pelvic floor physiotherapy, and education. So thank you very much, Mr. Chairman.